Chronic hepatitis B with early cirrhosis. It unfolds over years, often starting silently in youth, and becomes clinically visible only when the liver's reserve begins. He is a 41-year-old man from a semi-urban area who had felt generally well for most of his life. Over the past 2 years, he noticed gradual fatigue and reduced work endurance, which he attributed to age and stress. 6 months later, he began losing weight and experienced poor appetite, early satiety, and vague right upper abdominal discomfort. His family remarked that his eyes occasionally looked yellow, especially during periods of illness. He had no history of alcohol excess. However, in his teenage years, he received multiple injections at local clinics and traditional settings using shared needles. He also had a scarification practice common in his community. He never recalled an episode of acute hepatitis. Over the last 3 months, he developed ankle swelling in the evenings and increasing abdominal fullness. He sought care several times and was treated for gastritis and intestinal parasites with temporary relief. There was no fever, cough, or night sweats. On presentation to hospital, he was stable but chronically ill-looking. Examination revealed mild jaundice, palmar erythema, spider nevi ascites, and pedal edema. The long, quiet progression risk exposures, systemic symptoms, stigmata of chronic liver disease pointed clearly to chronic hepatitis rather than an acute illness. How history guided investigations. Because the story suggested chronic liver disease, medical staff chose investigations like HBsAg anti-HBC, liver function tests, INR, albumin, abdominal ultrasound. Random tests would not explain this pattern. Treatment and improvement. Diuretics for ascites, nutritional support, antiviral therapy when indicated, monitoring for complications. Symptoms improved with structured care. Teaching line. A disease acquired quietly in youth may only speak decades. Later history is the translator.